my personal journey actually informs my research, it informs my discourse, and it informs my relationships. And I just want to share with everybody this past Sunday, August 6th, I celebrated 29 years of continuous clean time. That's my but what I know today is the journey. Okay, but good. If you can hear me, let me know. So again, so that sort of informs everything that I do just in terms of my work. So our topic, health equity and implicit racial bias experiences by LGBT and community seeking recovery. So I'm also a member and part of the community, of the LGBT community as well. And that's another element of what I bring to the table. So when we talk about health disparities, there's a lot of different definitions of health disparities or health equity is. What I want to do is sort of put this in context so that we can understand health equity from a more holistic perspective, as opposed to this one-dimensional kind of perspective. Is everybody with me? So Healthy People 2020 has done a great job just in terms of their focus on LGBT, and they've come up with a definition around health disparities and health equity. So I want to share that definition with you because this really informs our conversation moving forward. And again, this is from a more holistic perspective. So when we talk about health equity, and this is the definition that Healthy People 2020 have. So they define health equity and health disparities as a particular type of health difference that is closely linked with, now here it is, this is what's important, economics, social or environmental disadvantage, health disparities, adversely affects groups or people of color who have systematically experienced greater social or economic obstacles to health based on their racial or ethnic group, their religion, their social economic status, gender, age, or mental health. In addition, it has implications for their cognitive abilities, their sensory, physical disabilities, sexual orientation, gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. As we move forward, this conversation and dialogue, I'd like you to consider those elements when we talk about health equity and health disparities. And everybody, so, let's sort of put this in perspective when we talk about why LGBT experience health equity. These are some of the elements. These are some of the issues that is particular to the LGBT community. Number one, and most pervasive, is stigma. The element of stigma encompasses that definition that we talked about in terms of health disparities. Discrimination, violence, family rejection, the lack of enforcement of legal protection for this community, shortage of cultural competence or cultural humility interventions, a lack of informed and educated healthcare providers, invisibility and erasure, as well as internal homophobia. And oftentimes these elements are a direct result of the stress that the LGBT community has to deal with in response to racism, discrimination, homophobia, those kinds of things. But what I want to bring your attention to is something very important, and that is how these sort of culminate into intersectionality. So when we talk about intersectionality, we talk about these elements as occurring at the same time. So for example, when we look at race and ethnicity, so certainly we experience racism from majority culture, majority community, or the general community, because that's a given. But with particularly Black gay men, not only do they experience racism outside of the general or the general community, they also experience racism within the gay community. So there's this tension, if you will, between white gay individuals and Black gay individuals. And the literature is full of examples of how that tension has played out. Example, the HIV/AIDS epidemic early on in the early 80s, when white gay men basically received funding from governmental sources, and very little of that funding actually went to services for the Black gay community. We had to literally fight tooth and nail basically to get funding. And it was through that process that we started to develop our own infrastructure for treating and helping individuals that were HIV/AIDS positive. Currently, we're experiencing the issue around intersectionality regarding immigration. So we've got individuals who are oftentimes leaving a country because they're being persecuted based on sexual orientation, and come over to this country and feel very unwelcome. And we hear all the time just about the climate that immigrants are experiencing in terms of how they are treated in this country. The other intersectionality is around religion, particularly in the Black gay community. We know that our church, our religious organizations are the only sort of autonomous organization that we really have in the Black gay community. But oftentimes homophobia is so entrenched in the Black gay community that much of that entrenchment is within the Black church and their treatment of Black gay men. The other issue is around age. And so we can even funnel this even further when we talk about ageism. There's the isms within the Black gay community. Mm-hmm. This notion about individuals who are older, who are oftentimes isolated, who are oftentimes sort of marginalized within the Black gay community. So that's certainly a consideration in terms of mental health. Also, the issue of body image. Oftentimes younger Black gay men particularly are so focused on this body image, but those that don't fit into that particular box oftentimes feel marginalized and left out within the Black gay community. And so I just want to sort of end this sort of opening with just some areas around health disparities that perhaps could be fodder for discussion amongst us. So these are some salient kinds of issues that are pervasive and particularly relevant for the Black gay community, or just the gay community overall. Number one, suicide. Suicide rates compared to the heterosexual community, compared to the white community, among particularly Black LGBT, the suicide rates are absolutely off the chart, particularly in this COVID-19 epidemic. And so some of the reasons are as follows: family rejection, institutional homophobia and discrimination, and again, as I mentioned, alienation from the gay community overall, and this lack of acceptance within the gay community. Second issue, depression from isolation, from loneliness, particularly older gay men who don't have the social infrastructure, who may or may not go out to bars and have that social outlet. Oftentimes there are not societal programs that will allow the engagement of this particular population in terms of resources and support. Eating disorder, that's the third one. Body dissatisfaction. And oftentimes there's a disparity in terms of the heterosexual community versus the gay community around anorexia and bulimia. And oftentimes this is an effort on the part of individuals who don't fit that body image, who doesn't have that buff body. And oftentimes they wind up either being anorexic or bulimic in order to sort of be more accepted within this community. And of course, substance use. And it really does suffice to say that within the gay community, and particularly among Black gay men, there is a rather significant disparity between substance use and prevalence in the LGBT community versus the general population. And again, that disparity is fairly significant. And so lastly, I just want to touch on what's as the big elephant, it's the elephant in the room, and that is HIV and the disparities that we still experience as a community around HIV. Example, according to the CDC, Black gay men are more affected by HIV than any other group. Some of this is directly related to the uptick in the epidemic around opioids, but also there's a increase in illicit drug use within the gay community as well, particularly stimulants, and particularly we're talking about crystal meth and cocaine, and we can sort of have a dialogue about that. But in 2018, Black gay men accounted for 26% of the 38,000 new HIV diagnoses. That's very significant. That's extremely significant. 37% of all HIV diagnoses are Black gay men. And here is what just stood out for me, almost knocked me off my feet. 3 out of 4 Black gay men between the age of 13 and 34 are HIV positive. So that group, we have to pay special attention to, particular attention to that 13 to 24 age group. And so I'm going to stop right there. I could go on and on and on, but this is your session. So you could ask me anything that you want. I don't say that I know every single thing, and that's why we have so many of you on the call, and you all bring a rich, cadre of experiences that can help enrich this conversation, and that's what I like to do. But some of the issues that I mentioned are certainly some ideas that we can bring forth in terms of discussion.
Thank you, Dr. Bryant. We appreciate you really just laid the landscape out really well for us to, just bite off a few of those things. I know we won't get to all of them today. But welcome again to everyone who may have joined after our introduction. But Ask the Expert through the Southeast Addiction Technology Transfer Center is a flip platform where you're not going to be sitting here for 50 minutes listening to a presentation and Q&A for only 10 minutes. So that was kind of just an introduction. Definitely want to get into some conversation if anyone has any, questions they want to share. This is Ask the Expert. So Dr. Bryant is our expert host for this month session. So feel free to either put it in the chat or open up your mic, turn on your camera, whatever you're comfortable with. You do have the ability to do that. So we can start some dialogue and start openly discussing some of the things that Dr. Bryant just touched on.
Hey, Dr. Bryant, thank you for sharing with us today. My name is Rob. I'm in Florida, in Tallahassee, the capital, and I oversee a treatment program. It's injectable naltrexone. It's also known as Vivitrol, and it's effective for treating alcohol use disorder as well as opioid use disorder. And so here in the state of Florida, we have about 3 programs to treat substance use disorder. And I noticed when the fiscal year closed out, I just did a report for our board, and I took a look at what the data is telling us here in Florida. And I'm thinking that there's an issue with the gatekeepers allowing certain patients and clients to have access to the treatment. So for example, injectable naltrexone, the shot is a monthly shot where you alternate shots on the buttocks, and it's approximately $1,400. And it treats alcohol use disorder as well as opioid use disorder. But our profile here in the state of Florida for the program that I oversee is 90% European American, and then the rest would be some Black and brown patients and clients as well. And I'm looking also at the data, and it's telling me that the majority of the patients that are being treated for opioids are European Americans. And then we have basically a few Blacks, Hispanics, and some Asians. but then there's a large percentage of the African Americans and the Hispanic Americans that are suffering from alcohol use disorder. And so there's a disparity with those ethnic groups right there. But when I think about when they first come into treatment, of course, this is covered, it's 100% covered here in the state of Florida for them right now. When they first come into the treatment, the conversation is not being had with them to direct them into the right treatment modalities. So I think the gatekeepers are part of the issue that we're having right now. What are your thoughts on it?
Good question. Thank you for that question. We know that in terms of evidence base, that for opioid use disorder, treatment, MAT treatment, medication-assisted treatment is the treatment of choice for this order. But there, again, as you mentioned, there are barriers. Number one, a lot of the gatekeepers, counselors, administrators, in my estimation, have not really been educated in terms of the effectiveness and the use around medication-assisted treatment. And particularly in some rural areas, physicians have to be certified in order to be able to even prescribe medication-assisted treatment. Mm-hmm. And so there's a lack of credentialing for individuals to be able to prescribe it. But I think the larger picture is this, particularly when you talk about African Americans. The conversation around opioid and opioid use disorder is almost totally relegated to white rural individuals, particularly white men. So the importance of opioids or medication-assisted treatments in terms of its effectiveness for African Americans, that conversation is just not being had. The national discourse is focused on white individuals. And so we are left out. And we're left out, for example, our community now, in terms of opioid use disorder, the prevalence rate and the new cases have an upward trajectory in the Black community, particularly in places like Washington, D.C., some places in New York. But again, in terms of the national discourse, African Americans are just not included in that process. So what's happening is a lot of the focus and conversations, particularly in treatment centers, are still focused on whites as opposed to African Americans. And I think in terms of the gatekeepers, that conversation really has to be had to the administrators in these programs that substance use disorder, particularly opioid use, really has to include African Americans as well as whites. Did that answer your question?
Yes, sir, it did. And, if you can talk about adverse childhood experiences, because from what I understand from patients and clients that are in the LGBTQ community, the ACE scores are really high, and this goes above and beyond a person's ethnic group, the racial background, religious background. The ACE is applicable to all ethnic groups, but in this particular community is really, really high for some reason. And that's the adverse childhood experiences, where they ask those 10 questions that are related to physical abuse, sexual abuse, and they answer those questions, and based off the 10 responses, this tells them if they are at a higher susceptibility for certain chronic diseases, including depression, and actually ultimately death.
You're absolutely right. And I think one of the issues that really needs to be more addressed, particularly around behavioral health, is the whole issue of trauma. And those childhood trauma, we know that those experiences oftentimes are carried throughout our life. And so the trauma has to be addressed, but also those experiences, those childhood experiences that you referred to are fairly significant. Just my own personal experience, when I was maybe 8, 9 years old, I was actually molested by a church member in the church on the pulpit. And that went on for years. And I think it was sort of overlooked by the church administrators because they were all family. But nevertheless, that experience infected and impacted my entire life. And I think that's part of the catalyst for the journey that I took. And one thing, and through this whole process, I went through 10 rehabs, but I never knew that that experience was not my fault. I thought because I was gay, that's just something that happened. It wasn't until we looked at issues around cognitive behavioral therapy, those kinds of things that really sort of unfold one's life history, that I was able to understand and process that and ultimately move beyond that. The other thing is 12-step programs. And I've been a member of a 12-step program for over 30 years. And one of the things that has helped me most in that process is the 4th step. And that 4th step really allows you to go through your entire life and unfold all of these issues around trauma, issues around family, issues around rejection, issues around lack of acceptance. All of that culminates into trauma over a period of time. And so I think the 12-step process has just been phenomenal, not as a treatment, but as a support mechanism for long-term recovery. And so I think, when you talk about how do we deal with these issues, most recovery programs really introduce the 12 steps early on in the program, but also encourage continued 12-step interaction and groups outside of the recovery process or outside of the recovery program.
Thank you, Dr. Bryant. Thank you, Dr. Rob Thomas. Sorry, I was trying to get the whole name. We appreciate that. Mr. Ed?
Hey, Dr. Bryant. First off, I am just finer than little frog's hair.
That's fine. That's fine. Okay.
That's fine. Thank you so much. First off, I definitely thank you so much for pointing out the fact, because a lot of times people just don't get it, that there is a horrible amount of discrimination and within the gay community. I mean, a prime example of that being, Atlanta has 2 pride marches. And a lot of times people just don't understand that. And that's why in so many, I know I'm over in Charleston, and there is a quote unquote, it's a separate bar that the African-American LGBTQ community goes to, as opposed to the other, I think there's only one now, that is predominantly white. And that's an important factor. One other thing that I don't think, because a lot of the research with respect to the coming out process and stuff like that is based on white gay men. And it's a completely different experience for gay men and lesbians of color. And one of the things, talking about HIV and AIDS funding, one of the things that a lot of folks don't realize is that a lot of that research that's been done with respect to what little bit there has been of sexual orientation was money taken out of HIV. So again, the research subjects were white gay men and trans women, because they had the highest incidence as opposed to lesbians and trans men. And this is just a casual observation, because I managed an opioid treatment program for about 10 years and worked in one for about 20. And one of the things that I've noticed, at least You know, in larger metropolitan areas, it might be different, but in places like Charleston, I think a contributing factor to the lower number of African American and people of color in treatment is the fact that they don't see a whole lot of other people like them. I mean, in the treatment milieu or in the clinical staff, which, you know, from a cultural, you know, standpoint, I think that's important. I mean, we talk about it being important with respect to, you know, making treatment programs welcoming for LGBTQ folks, and the same thing applies to other folks, other groups, that the staff and the patients need to reflect the community. But, you know, thank you so much for all you're bringing up, because it's an interesting topic that a lot of times I don't think we talk enough about. And with that, I'll be quiet.
Thank you. And you brought us some really important points. The first one I want to, so you mentioned the discrimination within the gay community. So you would think that because as gay individuals, we are all in the same boat, that there would be a lot more empathy, that there would be a lot more understanding in terms of race. But what I've come to understand, and much of the literature supports, is that race in this country even transverses sexual orientation. Mm. And case in point, when individuals, organizations sprung up when HIV first started, and they had these advocacy kinds of organizations, a lot of policies were changed based on that advocacy. Money started to be poured into the gay community, because what politicians and white gay individuals understood is that and I may not even approve of your sexual orientation, but I do approve of your whiteness and your privilege. And that sort of culminated in funding being transferred into the white gay community, but not being disseminated into the Black gay community. And in terms of the experiences, and a lot of these experiences are cumulative. So we know that bars, and in terms of social spaces, are where gays oftentimes congregate. It's usually a safe space. It's usually a space where, we can meet people. We can let our hair down. We can dance. We can do different things. But the experiences that Black people of color have had in those spaces is oftentimes when you walk into a white gay bar, you're asked for 3, 4, 5 pieces of identification if you're a person of color or African American. So in other words, they're saying to you, we don't want you in this space. And that's historically, and to an extent now as well, has been pervasive throughout the gay community, and really reflects the racism that I'm talking about. And what would happen is when white gays who went to a particular club, when the club owners start to lose business and their clientele, would move to different spaces, that's when they would allow Blacks to come in. And the sad part about it is because in terms of these spaces and these clubs, Blacks really don't own them. We wound up finally being led into these spaces, not because of equity, but because they've lost their white clientele.
Very good point. You have a follow-up for that, Mr. Ed, or you want to move on?
Well, no, I mean, one thing I would like to, you should know me better than do I have a follow-up. Any opportunity that Ed has to run his mouth. But one of the things that I think a lot of my, the people that I know down here that are you know, and I'll define myself as a European, a cisgender gay male of European descent who is of a certain age, that we won't go there. But I have privilege. I have the white privilege. And it doesn't matter whether, you know, you're gay or not. I mean, when it comes to whiteness, it really isn't relevant. I mean, you know, yes, there might be a tad, but it's like getting it. It's like, kids, you have privilege based wholly, solely, and completely on the color of your skin. And it's important you acknowledge that, you know, because you can't get on with the business of dealing with things until you acknowledge the fact, yep, I got it. So I'll shut up again.
We appreciate you acknowledging your white privilege, because members of empowered people are ways, especially as not just actors or allies, but actually accomplices to this fight and racial implicit biases and just the whole conversation of being anti-racist. So we appreciate you acknowledging your white privilege. I think that's the first step to starting many of these conversations. So we thank you just for that. Speaking of a woman of color.
Speaking as a woman of color.
-WOC. Samira, I don't want to mispronounce your name, but I do see you've come off mute. Please ask the expert. I do want to mention that Don Tyus and Ed Johnson are on the line, and they're also part of the team. Don Tyus is our director of SATTC, and Ed Johnson is the associate director of training and TA. So we do thank both of them. So they definitely are always vocal. So we appreciate Mr. Ed whenever he gets a chance to talk and speak to us. So go ahead. Thank you for coming off mute.
Oh, of course. I believe we work with Don Tyus, because I'm with the University of Pittsburgh for Peru. So we work with substance use and preventative initiatives across Pennsylvania. So one of the questions I did want to ask Dr. Bryant is, we're currently trying to implement SBIRD screening, prevention, and referral to treatment in emergency departments. We usually do it through primary care clinics or pharmacies. So now we're kind of branching out to emergency departments. And we usually do a lot of stigma surveys to see kind of what's going on with the organizational health and, you know, how we could proceed. And we've been seeing that there's a lot of stigma when it comes to patients who come into the ED that aren't aware of their substance use, kind of like repeated patients who always come in. And we found that nurses and providers, mainly for like physicians, if they're older physicians, they have a higher stigma to address any issues. And the site that we're working with, they don't even have any providers that you know, are licensed to do the MOUD, like you said. So I'm kind of curious to see if you have any advice on how to move forward when it does come up kind of with stigma in such organizations. We're having stigma with providers, like physicians kind of becoming more open to MOUD and treating patients with substance use disorders, as well as nurses when it comes to basically they have less sympathy for patients who come in repeatedly and not being aware of their substance use, kind of just repeated visits and not, you know, addressing that, realizing that they have a substance use disorder.
Great question. So I'm going to try to unfold that. So I've been working as a respiratory therapist for 45 years. And so when we talk about nurses and physicians, particularly around prescribing opioids and prescriptions, and I must say that we really have changed in terms of our attitudes about individuals in hospitals, including the emergency room, and pain. It used to be that nobody in the hospital would be allowed to sort of be there in pain. There was usually a scale that we would use from 1 to 10, and we walk in and we ask the patient, what is your pain level? And if it was anything over 3 or 4, we treated, we automatically treated. Well, that has stopped. Treatment or evaluations of hospital by patients when they leave are no longer tied to pain. It used to be that if they gave you a bad score in terms of your pain management, that was a ding towards the hospital. So I think that's one improvement in terms of just the awareness of individuals in the hospital, including physicians and nurses, around pain management. And so now the CDC has a set of guidelines in terms of pain management that most physicians are now following. They're very specific guidelines in terms of pain management, and it's cumulative, just in terms of the information that is provided in education for physicians. Secondly, when you talk about sort of a lack of understanding among some physicians around prescribing, particularly opioids, one of the things that has happened, and I worked with the Department of Public Health here in Georgia, and we set up a statewide strategic plan for the opioid epidemic, and part of that plan was the prescription drug monitoring program, we call it PDMP. That has changed the game totally. I don't know if anybody has heard of that, but it is a monitoring program, and we helped institute that. It initially was with law enforcement. They weren't doing anything about it. And as prescribing, just went off the charts here in Georgia, we brought it over to the public health, and that's when the difference occurs. So now physicians are no longer, whether it's the emergency department or whether it's in an ICU, are no longer to prescribe, for example, 3 months worth of opioids. This prescription drug monitoring program keeps track of every single dose of opioids and prescriptions that a particular patient has. So when that patient comes into the emergency department and they are being asked, or they are asking for opioids or prescriptions, the physician can go right to the computer and do one click and see if that particular patient is actually doctor shopping, if they've already been to other physicians in terms of prescribing. So I think that has really made the difference. We've seen a decrease in terms of opioid use disorder here in Georgia. And not only is it in Georgia, but it's also in the neighboring states as well. So individuals can no longer go to Florida, to Tennessee and other places. We have an agreement, a multi-state agreement that really helps to mitigate that. And so the other thing, and just in terms of attitudes around pain, a lot of people ask, well, why aren't African Americans or the prevalence isn't as much in the African American community as in the white community? Well, historically, there's been racism in terms of how prescriptions are prescribed. The literature supports that African Americans, in terms of physician prescribing, are less likely to be prescribed painkillers or opioids than their white counterparts. And that's one of the reasons why you see this difference in prevalence between the white community as well as the African American community. And lastly, to your point, another thing that we realized in working with the Department of Public Health is that physicians, in terms of their credentialing, as part of that credentialing process, they had to have a certain amount of hours, educational hours, around prescribing, around opioids, around the social behavioral kinds of implications of communities that they're serving. And I think that while that's still a process, I think that was one step in the right direction in terms of educating physicians, not only physicians, but also medical schools. Very, very important that we get these physicians before they graduate and help them to practice from a more informed perspective.
Yep, that's something we talk about at MSN, Morehouse School of Medicine, quite often, about, you know, catching them in education and integration before practice. So yes, very good point. Miss Liz has a question. So thank you for answering Samir's question, Dr. Bryant. Liz, if you wanted to come off mute, we can read the question if you want to elaborate on it. But we need to know, how do we best amplify the voices and meaningful engage the LGBTQIA+, so I left off a couple of letters, population and all of the subgroups that we are talking about today to be a part of public health efforts. And I can echo that as well. I'm hearing there's a sexual minority group as well as a racial minority group voices that are, you know, kind of needing to be heard. And so, Liz, if you wanted to, you know, add anything to it by coming off of mute, feel free. But yeah, that's the question, Dr. Bryant.
Okay, is any more to that question?
Nope, just how do we best amplify the voices of these two populations and meaningfully engage them?
Okay, so one of the things I think has to happen is that in our educational endeavors, in our research endeavors, LGBT need to be at the table. I was a part of the HIV/AIDS network trials, which is one of the most comprehensive HIV/AIDS network trials, and it was worldwide. But I partnered with Emory University in order to do that. So you're looking at HIV/AIDS intervention among African Americans. And one of the things that we knew early on, and we complained about, and these were the researchers that were African American, is that there were no African Americans at the table when the design of the programs, at the inception of the program. When we talk about community-based participatory research, and certainly Morehouse is very, very adept at, and that's where I learned, because I worked at Morehouse in the Prevention Research Center for some years in early 2000. And so when we talk about community-based participatory research, that means that the voices of the individuals that you're doing research on should really be included at the table. And so I actually did a paper on this, and on that project, we developed what we call the Black Caucus. And so that caucus made recommendations, or we made recommendations to the administrators and those leaders in the program in terms of what we thought were best practices for inclusion of African Americans, because, you know, we're the ones that you're doing research on, and you're doing this comprehensive worldwide research, but we were not at the table at the design process. And so I think that's one of the ways that we can include LGBT in any kind of effort where they are being supported or they're being researched on. And I also think that in terms of, we talk about cultural competence and really looking at healthcare providers, counselors, and individuals that are working with LGBT to really be competent to work in these communities. And I even go further than cultural competence to cultural humility. And that's a process where you're really providing the kind of services to individuals that respects who they are, respects their individuality. You know, one thing at Children's Healthcare of Atlanta, and I'll tell you, I really give them kudos for this, because we had a whole sort of educational kind of program that every single employee had to take this course, and it had to do with transgender individuals and how we should respond to them, how we should treat them, how we should identify them. For example, it's important that we address people how they want to be addressed. And how do we know that? We know that because we asked them the question. We asked them, how would you prefer to be addressed? Except in matters that have medical implications, in terms of their assignment at birth, may be relevant. But other than that, just the whole idea of respecting an individual's personhood. And I think that that's a program that should really be, pervasive throughout our community-based organizations, throughout our hospitals, that kind of thing. So, SATTC has really provided also a document. It's called Language Matters, and how we can better address individuals, based on respect and based on a language that doesn't demean them or that doesn't disparage them. And so I think those are some of the things that we can do just in terms of how we can better respond to LGBT.
Thank you, Dr. Bryant. We actually, Mr. Ed speaks on Language Matters heavily, and he just gave a presentation on that, last week, I think. So that's definitely something we hold dear. You're welcome, Liz. Thanks. If you wanted to add anything, Liz, feel free to come off of mute. I see Mr. Ed has as well.
No, it was with the Department of Corrections, which is definitely definitely a group that, that's the thing with language. We use terms that we don't stop to think what they mean. We don't stop to think where they came from. And that is one of my big things. And that is one of the nice things about, having been in recovery for a while, is you can get away with busting people. It's like, that is just the tackiest thing I have ever heard. So yes, language is important.
We have, but if anyone has another question, we have like 4 or 5 minutes left. We do end on time as well as start on time, so we will get you all in here right at 3, if not before. Does anyone have any last and final questions for Dr. Bryant? Anyone who hasn't spoken?
Last question for the doctor. So we know that we're talking about opioid use disorder as our big public health crisis right now. But that 500-pound elephant in the room is tobacco use disorder, TUD. So we know that 90 to 95% of the individuals that suffer from OUD also suffer from TUD. And if we don't treat both of these simultaneously, the literature tells us we're supposed to do that. And we also know that this particular group that we're discussing today, they have an extremely high affinity for tobacco. So what are your suggestions about this particular group that we're talking about today, tobacco, and its overall treatment that we're supposed to do for them? Thank you.
You just have the most phenomenal questions, I tell you. You got my head thinking.
They are.
But it's a good question. And, and it's come up, fairly frequently, both inside the recovery rooms as well as outside. Here's my thing. When we look at substance use disorder, we look at its effect on individuals. We looked at its pathophysiology, both in terms of neurology and other physical kinds of things. Of course, tobacco, we know, is very deleterious. It has all kinds of health implications, but tobacco does not cause the same kinds of things that opioid use disorder causes. So I think rather than trying to sort of mitigate both problems at the same time, unless an individual wants to. Now, my own personal recovery, I stopped smoking and I stopped doing drugs at the same time, but everyone is not able to do that. And that's why programs, it's really important to sort of not put this one size fits all, kind of, response to individuals. And it really has to be more individualistic in terms of, programming. So I would say if the individual is ready to stop smoking, certainly do it. But if not, I don't think that is, at this point in time, a deal breaker.
Thanks, Dr. I think Ms. Dawn has something she wanted to say, because I know we're about to close. Ms. Dawn?
Yeah, we're about to close, but I'm sorry. Thank you so much, Dr. Bryant, for always your willingness to participate and to step in and help the help SATTC. And I think was a very informed conversation, and I think it's one that we definitely need to keep moving. But my question is, we have a lot of individuals, especially in the African American gay communities, with males who are still, they're not there yet. They're not. And oftentimes when they go to community providers, and especially in a lot of rural areas, they don't know how to actually deal with the population. What are some of the some basic evidence-based strategies that community providers can employ when working with this population?
Well, that's another good question. So there are several community theoretical kinds of programs or interventions that I think have implications here. One is contingency-based therapy, and that is therapy that really is sort of a reward kind of process. So it really looks at this reward system for individuals who stay in treatment, individuals who may participate to a lesser extent in harm reduction kinds of strategies. But at the end of the day, their substance use is lessened or stopped altogether based on a reward system. And so that is one treatment method that has worked in the LGBT community. Another program, and I mentioned it before, is CBT, and that is changing one's thinking. And in that process of changing one's thinking, it then provides for a better coping mechanism. And even in recovery circles, one of the first things that we learn and that we hear over and over again is that our thinking has to change. And so this intervention helps the client learn patterns of a change from unhealthy behaviors to more healthy related behaviors. It helps to increase one's confidence in their own personal abilities, helps individuals to face their fears, and also engage in activities such as role playing. And so these kinds of interventions have proven effective in this population. One program that is fairly new, but I think is creative and innovative, and that is the STRIDE program. And that is it's a clinical trials, basically for stimulant users. So we're looking at crystal meth, methamphetamines, cocaine, those kinds of drugs. But this is an exercise program. It's an intense exercise program. And it has been compared to just an educational program by itself, but it has proven, particularly for African Americans, to be a very, very innovative and creative program to help individuals sort of replace that addiction to chemicals with something more positive. And exercise or intense exercise has helped individuals to stay in programs longer, also helps to sort of mitigate the overall way that an individual feels about themselves, self-acceptance, those kinds of things. So these are the kinds of evidence-based programs I think that are certainly responsive to the needs of LGBT, as well as 12-step programs. Now, whilst 12-step programs are not treatment, they are support. And as I mentioned before, I don't think I would have survived without 12-step programs. And there are 12-step groups that are specific to LGBT. Here in Georgia, we've got several groups that really supports and deals with issues related to LGBT. Does that answer your question?
It really did. Thank you so much. Very informative. Thank you.
And if I could just take 1 minute to really talk about some recommendations. You know, I'm the kind of person, I don't like to leave a session without some action-oriented kinds of things. Like, it's good to have conversation, but what do you do when you leave the conversation? What are the tangible kinds of things and information that you can go home with that will make a difference in your daily practice? And I had the privilege, you know, in working with the Department of Public Health and receiving a grant to do a multicultural needs assessment among LGBT and among transgenders. Now, we did other groups, but those are the two main groups that we're talking about now. And some of the recommendations that I just want to share with you in terms of what we did focus groups, and we also implored expert input from community-based organization administrators and directors. And some of the things that came out of the focus group particularly were the fact that counselors and professionals should be more empathetic and non-judgmental in terms of culturally relevant therapy. Again, we talked about behavioral health as also an element that should be included in therapy as well. And one of the things I thought that was really, really innovative was peer support. So peer support should be consistently available across all cultural groups. Those are just three of the more salient kinds of recommendations that were made. And I could send the entire report to anybody who wants it, because we're now in the process of disseminating. But I also want to share three salient points that our key informants said. So these were people just like you, community-based organizations here in Georgia said, this is what we think needs to happen. These are the recommendations. These are action steps that actually need to happen. Number one, just across the board, eliminate stigma so that it does not prevent substance use users from seeking treatment. And we know that particularly in the African-American community, stigma really does prevent many of our clients from accessing treatment. Also, the issue of polysubstance use has to be considered, because almost never will you find a person that overdoses or that has a substance use that just uses one substance. There's this polysubstance use disorder that has to be addressed. And the third salient point in our study was to legalize and promote syringe exchange for intravenous drug use. We know that HIV is not going to go away. It is not going to decrease until we address the issue of intravenous drug use, because that's how it's being spread, and also hepatitis C as well as other STIs. So those are just a few of the points that or the recommendations that were made by communities just like you, individuals just like you. When we talk about community-based participatory research, this is the heart of the kind of research that we love to do, where the community is involved in recommendations to make their life and their access to treatment better.
Thank you, Dr. Bryant. I know we did go a little over, but those were excellent points that I'm glad you brought up at the very end. We would love to take that document or whatever piece that you want to share with our ATTC community and have it as a resource mention. Since this is a part of our strategic initiative, we definitely had recorded this session, so it'll be available in the resource mention. So if you care to share, not the entire thing, the pieces that you just shared with us.
The whole piece pie.
Awesome.
The whole pie.
Awesome. Well, on the behalf of the Southeast Addiction Technology Transfer Center, which is at Morehouse School of Medicine and the National Center for Primary Care, this is Ask the Expert, and this is our August session. Please join in on September. Well, we cross our fingers and hope that our director of NCPC, the National Center for Primary Care, will able to come to us and speak on the integration of primary care and what role it plays in the SUD's treatment and recovery, as well as some of the racial and implicit biases there. And that will be the last session and kind of this kind of mini series in our Ask the Expert, where you can hear a little bit more about that integration of primary care. And since that is what we do at SATTC and NCPC. The recording will be on our SATTC website, and so I can share it with the people who registered for this Ask the Expert as well. It'll be on our website, and I can send it to you all in particular. So you'll get that recording. It'll have to edit it, brush it up a little bit, since we had some, just to make sure we didn't catch any of Dr. Bryant's audio challenges in the beginning, so it won't be available today, but I can get it to you by Monday, just so we can clean it up and just make sure you're able to hear it. But we appreciate you guys coming. I'm Celine Craig. I enjoy doing the Ask the Expert. It's always the second Tuesday of every month. We did have to push it back for this month, but it's always the second Tuesday of every month, 2 p.m. Eastern Standard Time. On the behalf of Don Tyus, who's our director, and Ed Johnson, who's our Associate Director of Training and TA, as well as one of our Training and TA managers, Nikki Harris. We appreciate you joining. And thank you for joining us today, and have a great rest of your week. Enjoy. Congratulations for any parent who went back to school with their kids virtually. You guys can do it, and you'll make it through. Have a good one. Bye-bye.